Hello, this is a presentation I gave earlier today to the third annual Oncology Hematology Summit here in Eldoret, Kenya. It was on the AMPATH medical record system and given to a group of clinicians, researchers, industry, patients, and administration. Today, I want to speak about how the electronic medical record impacts the patient through access to their data, the clinician through clinical decision support, task shifting, and user interface design. It impacts the facility and administrators through dashboards and analytics, and ultimately researchers and industry through access to data. And I hope by the end of the presentation, you walk away as excited about the work being done here in Kenya to build a world-class medical record as I am. But more importantly, I want you to realize that the goal of this team is not to build a model, the goal of this team is to build a model of healthcare delivery in oncology where we have screening in the villages and bringing people into care at secondary and tertiary levels, and in particular to create a complete oncology delivery system which works also for the poor and informal sectors, and hope that we can create a model which will be adopted and shared by other countries around the world. And AMPATH did this exact thing years ago when they were working in HIV. They didn't wait in the ivory tower for patients to come to them, but went out into the villages to screen everyone and to connect them into care. And what we'll see here is that the building of a medical record is simply not the building of a record database or a data warehouse, but this actually is creating the roads and infrastructure which you build a healthcare system on top of. Just before we go on, I want to make a quick aside. I've only been here in Eldoret for 3 months, and so whenever I use the term we to discuss the work that we are doing, I have not been a part of these great things which have been done. It's really our team here, which is a tool built in Kenya for Kenyans by Kenyans. And I just want to quickly draw your attention also to two other people. On the right is Nikki Kimania, who's our lead developer and head of the programming division. And on the left, we have Dr. Jonathan Dick, who's an informatics expert from the Regan Street Institution, as well as an internal medicine physician. And the two of them have really made this possible with the rest of our team. Let's move into the first part, how the medical record impacts the patient. AMPATH built their first large electronic medical record in 2004 with the help of a global community in creating the Open AMRS platform. It's currently used in over 80 countries around the world, and as I said, this product came out of a vision from here in Eldoret. 3 years ago, our team built on top of the OpenMRS platform a new front end, meaning the product you see when you open a Chromebook or desktop or lap or tablet. And this front end we call the AMPATH Medical Record System Point of Care, POC, and that's because this here is designed to be used in real time in the clinic. And the way in which we make this happen is that we installed solar panels onto the roofs of dispensaries to secure the power system, connected this to a battery, as well as installed an antenna on the roof of the dispensary so we could connect through the Safaricom connection directly the devices in those clinics through an encrypted line to our server here in Eldoret, which is behind biometric security in a climate-controlled room. And from this, we're able to have a single hub which keeps the entire system in sync in real time. I want to point out that to date, we have recorded over 8 million visits. And in these visits, we have recorded over 250 million clinical questions that have been asked of patients. And so when you hear about big data, we have big data. And we are excited that oncology has shown tremendous drive as they want to move from paper to digital, just even in the last 1 to 2 years. They have built out program forms and it created the ability to see patients in their clinics. I'm going to just show some. So I'm just going to show some screenshots now. And admittedly, these are screenshots using our HIV module. It's mostly because I was under quite a lot of time pressure to compile this presentation and have these readily available. Also, some of these screenshots are still in the QA phase and final development phase from our development team, and so they aren't available. But essentially, the oncology department has built out the ability to see patients in visits. They've created the ability to see vitals, to check monthly status of patients, and do scheduling. In addition, oncology has shown tremendous ambitious plans to upgrade the system this year even more. We're looking to install barcode printers in the lab, which can place the patient's number onto the phlebotomy tubes. Those tubes will then go to their lab machine, which they'll scan into the device. And we're looking at creating a FHIR API to run onto their lab machine so that our electronic medical record can pull the records in real time. They want to develop a way to digitize their radiology reports, their pathology reports, and the histopathology reports so that we can view both the text and imaging from these reports in the system, and develop a patient feedback and survey module which they can give their patients, and also integrate fully medications in the pharmacy system. We'll move now into the second part on how the medical record can help clinicians. Here in Kenya, we speak of clinicians as everyone from community health volunteers all the way through many levels of care up to someone such as Professor Chite with advanced degrees from around the world. And the medical record can help each type of clinician, from someone with minimal medical training to advanced, in three ways. The first is with clinical decision support. Clinical decision support allows clinicians to know what the next best step is. And so we can build this in so that the person working at the dispensary knows when to screen someone for breast cancer or cervical cancer. We can help a nurse or clinical officer at a secondary level facility know when their patient's immune system is too suppressed from the chemotherapy received. And we can allow someone, perhaps such as Professor Chide, to know when there are up-to-date articles or publications related to the patient he is seeing. We also want to use cutting edge machine learning to help improve our clinical decision support. None of these exist currently for oncology, but of course, with the support of our partners, we can try to make this happen. The second way that it helps is through task shifting. And task shifting, I think, is really crucial because it allows work to move from a higher level clinician to a lower level clinician, and to be able to do this work safely. And to me, task shifting is going to be one of the magic solutions on how you scale healthcare globally, especially to the 5 billion people which don't have it. Because you can combine a powerful electronic medical record tool with a clinician who may not have very high levels of training and allow them to provide safe care on a global level. And the third is through the user interface. We want clinicians to love the medical record system so that they want to use it, so that they don't want to go back to paper. And we're undertaking a significant effort to rethink AMRS. And we call this idea AMRS 3.0. And that's a whole other talk you can find on YouTube if you type in AMRS, OpenMRS, Electronic Medical Record, Foundational Design Principles. The talk under my name, Gregory Schmidt, should come up. But essentially, we're trying to rethink how to build a system where clinicians can see clinical information and write notes all at the same time, where we rethink the system from first principles of how to do visual design, as well as the ways that clinicians think about data, and make something which is really exciting to use, and something which isn't out there currently like this. And a system where you can integrate multiple types of care visits all into one clinical appointment. Because as I keep talking about in my different presentations, at AMPATH, we're moving out from just trying to do HIV care to really tackle full on the idea of population health care or comprehensive primary care, which is the way to deliver ultimately a universal health care product. The third way which I want to talk about the way that electronic records help users is focusing on how it helps facilities, administrations, and government. Here at AMPATH, we've developed many databases and dashboards for the level of our HIV program. And I want to show you something we're doing now on a tool called Kibana, which is a tool we've recently been able to integrate. And so these are some very early dashboards which were created just in the last few weeks for our HIV program. As you can see, we're able to produce a lot of numbers on a screen at once. This here is a Ministry of Health level report, meaning that the data is of the right quality that they can access it and use it from our system. We send them these reports on a monthly basis. You can also view the information in graph form. When I presented this, it's too small to read most of the text, so it's just to give the general gestalt of what can be done. It can be filtered by time, by county, or all the way down to specific clinics. And when you perform these filter and search results in Kibana, the updates happen almost in real time. This is just a chart where you can see a target indicator and how we deviate from those indicators over time. You can compare clinics across time. This is a really great tool if you're trying to build a system. You can also build very simple dashboards, which may be easier for users who aren't as interested in the detailed data, or you can build really detailed dashboards like we have here, which is this one I took these screenshots was a real-time picture from today of the entire AMPATH HIV network. And so we see exactly which sites had the most traffic today with new patients coming through them. We see the time that those patients were triaged and the time that they ultimately had their clinical appointments. So we also can look at the time that it took for that appointment to occur and how much time they spent in the clinical care and how much time they spent at triage. And you can look at the number of programs by visits or the number of clinics by visits. And, as I said earlier, at AMPATH, we're not building a data warehouse. We are building a healthcare delivery system. And so these are the types of ways which you can actually look at the system performance is with these types of performance metrics. You can look at the individual clinicians to see how many patients each of them saw, if you wanted to see which are maybe more having a longer tea break or which are really seeing a lot of patients. You can look at all the different forms in those clinics which are being used, the number of minutes it takes to complete each form. You could even run potentially an A/B test where you create two different versions of a single form to find out which one ends up being quicker to use. And then theoretically, you could connect that data to figure out the outcomes of the patients. This graph is, as you can see, calculating the 50th percentile based on time to complete these individual forms. These visualizations look very complicated, and they're actually reasonably simple to create. And so what we are looking to do is use minimal training to enable any user who's interested, and of course has the permissions, to be able to access this data. And you could go back and filter this entire graph simply by clicking on breast screening, and it would instantly filter this page to show you those two sites where users ended up having breast screening as part of their HIV care appointment, as you can see. And you can ultimately filter a patient level list. And if you clicked on one of these names, it would take you directly to that patient's chart in our medical record system. And of course, we could also block that ability if the user who's viewing this dashboard shouldn't be allowed or permitted to have access to patient level data. So we're pretty all excited about this new ability of data visualization through Kibana. And as I say, that's just the start. We just created those HIV dashboards within the last few weeks. And this week we started building some oncology dashboards, which I anticipate should be out within a month's time. Fourth, let's talk about researchers and industry and the ways that medical records can help them. ultimately, we collect a lot of data, and that's a crucial part of industry, of clinical trials, and of research. And in speaking with people yesterday at the conference, it became very apparent that REDCap is a crucial part of your research pipeline. In that, one, my understanding is from speaking with people that it is approved by the FDA for reporting standards, and it structures data in the way that, for instance, pharmaceutical companies like to use it. And so I think after doing a bit of research yesterday evening, that it appears that REDCap has an ability to connect to a FHIR interface, which is an official standard on how to do electronic data exchange. And it's very reasonable that a high priority of ours should be to connect the AMPATH medical record system into REDCap and to create a two-way street here. I think that this would be a win-win scenario for everyone. First, from the clinician point of view, that means that they're able to use a real point-of-care system, the AMPATH medical record, when delivering care, and they don't need to have some sort of separate REDCap system that runs on another set of tablets that they re-enter the data into. This is a win for the industry partners because they don't need to pay to build their own data collection strategies. And it's a win for government because it means that more data potentially is being captured into the medical record point of care system. It's a win for us as the EHR because in theory, some willing founders and sponsors could help fund the development of a more robust medical record system. And it's a win for the patient because as we've been showing, a better management of data ends up being able to create a better care delivery system. And so to conclude, 15 years ago, AMPATH led the development of a global effort to build AMRS, an open source electronic medical record used in over 80 countries. 3 years ago, we took the leap to build on top of AMRS a real-time point-of-care system, as we've seen today. And today, I hope that together, with your support, we can take the next step to lead the global effort to build a more powerful system on top of it, one that fully integrates all patient information, a system that drives clinical care through advanced clinical decision support with some machine learning, extensive task shifting, and an amazing user interface and experience. This comprehensive system will allow data analysis of both medical care and system performance, and will be a powerful tool to researchers and industry through seamless integration of our system into REDCap. As I said at the start, we are not simply trying to build a data warehouse, but we are trying to build a healthcare system. And this IT is ultimately that road and infrastructure network which you need to build a system on top of. We see that the work which we can do here on Oncology to build out the system better for them has the synergistic benefit of benefiting every other user in the AMPATH network, so HIV, chronic disease management, population health management, because it's the same system we use across our entire program. And this is not a vision or a product which should be confined to Eldoret or to Kenya or to even East Africa, but really needs to be shared on a global level through our other partners. But ultimately, such a vision requires financial support from visionary companies who want to be able to build a oncology healthcare delivery system from the village through to tertiary consultative care here in Kenya, and to create a model which can also serve the poor, which can serve the informal sectors, and which can serve as an example on how to do this for the global community. Thank you very much for your time today.